Hi, Mike Gibson and Zoltan Turi come to you live from SCAI 2015 here in San Diego. Zoltan, talk to us about the left atrial appendage. What's the history of this? It seems like it's like the Rodney Dangerfield of the heart. You know, it doesn't get a lot of respect, hasn't had a lot of attention until recently. So go through the history of the left atrial appendage.
Well, it's caused a lot of trouble over the years.
Yeah.
And to some degree has been neglected, certainly neglected in terms of high-level evidence base. Our surgical colleagues began doing relatively modern heart surgery in the late 40s, things like mitral stenosis surgery, close commissurotomy in particular, and they became aware very early on that the left atrium harbors clot. They were very concerned about clot embolizing during the procedure, and they began a series of, over the last almost 70 years, ad hoc procedures to try to address it, drive-by amputation or clipping or suture ligation of the left atrial appendage.
None of which has a high level of evidence, as you said.
No, there's been one aborted trial, the left atrial appendage occlusion study, and there's actually a new version of it now, a 4,700 patient trial. So I think we're going to get there, although that has limitations. But it wasn't until, as usual, cardiologists got involved and a new technology, which the FDA mandated, have a pre-market approval study and a pivotal trial that I think has led to some higher level evidence base.
Yes, yes. So talk to us a little bit about some of the FDA panel reviews of some of the newer devices, stumbling blocks, how we finally got there in terms of approval.
So that's a long interview, but basically there was a patent application in '98 for one of those brilliant ideas that we all wish we'd had, which led to the Plato device, and that began a series of pilot studies in the early 2000s, both of the Plato device and then more recently the Watchman device. Which led to an eventual solid randomized trial, 800-patient study, PROTECT AF, and then a subsequent study that the FDA mandated after the first panel hearing, which was the PREVAIL trial. There have been an unprecedented 3 FDA panel meetings, and partly because the data have been both positive and also in some ways equivocal and at times disturbing. There were a lot of adverse events early on. I think there was a big learning curve.
Sure.
Once that learning curve was addressed, the safety has become much less of an issue. In fact, that was the only thing in the last panel that led to a unanimous vote that that issue had been addressed. There are, however, significant residual issues about efficacy. So not to get into too much detail, but the PROTECT AF trial, in its final analysis with about a mean 4-year follow-up, has shown efficacy in reasonable, compelling fashion, I believe. But in the meantime, the FDA mandated the PREVAIL trial, which did not show efficacy. And so it's a complicated Bayesian analysis. The analysis includes half of the patients in PROTECT AF. But the bottom line is safety was shown, but efficacy looks really quite equivocal, with particular concerns about late ischemic stroke. So that's.
And what would be the mechanism of late ischemic stroke?
Well, you include the left atrial appendage, but it doesn't mean you avoid all risk of an embolic event. And first of all, some clot occurs outside the left atrial appendage, and the meta-analyses look like somewhere between 6 and 10% in non-valvular AF. It's much worse in rheumatic AF. So that's one potential risk addressed to some degree by antiplatelet therapy, typically aspirin, in the long run. There's also an issue of potentially leak around the device so that blood and clots can potentially get in and out of the left atrial appendage. It's a little unclear. It's probably not the only issues. People have what look like ischemic strokes from a number of potential other possibilities over time. So I don't want to blame device completely for that.
I understand.
But that has been an ongoing concern.
So what's the final kind of indication going to look like? I know we don't have all the final verbiage, but if you were to predict, what would it look like?
Well, there are really 2 categories. One is what the studies actually looked at, and the other is what most of us as clinicians want to do for our patients. So the studies, because they randomized, the control group took anticoagulation. The randomized trials all looked at patients who could be anticoagulated and who could in fact take anticoagulation for a prolonged period of time, specifically warfarin. They didn't look at the patients who
you'd really want to put this in, who you can't anticoagulate.
That's correct.
Yes.
So it didn't look at NOACs also, by the way, these studies. But the patients who are the intracranial bleeders, the GI bleeders, the old patients at fall risk, all those sorts of patients with a high CHADS or CHADS-VAS score. So high bleeding risk, high stroke risk, high embolic stroke risk patients are the ones we desperately need good technology for.
Right. Where do you see the future in this area?
I think it's reasonably bright now that the FDA, after the third panel, approved the devices. I was very concerned that it was going to kill this technology for the foreseeable future. I don't think that's going to happen. There are a number of competing technologies. I think it's going to lead to considerable expansion of interest. I think it's going to lead to better trials. And in the meantime, most of us are hoping that we will at least be able to put some of those patients, the unanticoagulable or very hard to anticoagulate patients, that we'll be able to put these devices in there because we don't have any real on-label alternative.
Right, right. Zoltan, thank you for coming by today. You're a busy guy.
Thank you so much.
Thanks for sharing all that historical data with us and insights. And thanks for joining us here live from SCAI 2015.